Welcome to Unit 2 of this Planning for STI Service Provision module. In this unit, we will look at core components of antimicrobial stewardship. By the end of this unit, you will be able to describe core components of antimicrobial stewardship, or AMS, aware classification, and antibiotic prescribing. Facing the challenge of limited resources, there are several options for detecting STIs and other RTIs in pregnancy. We'll now look at these in more detail for syphilis, gonorrhea and chlamydia, and common vaginal infections. Identifying syphilis in pregnancy is high priority to avoid serious consequences of congenital syphilis. Many countries have adopted policies and guidelines for elimination of mother-to-child transmission. Fortunately, there are several reliable diagnostic options for syphilis. Rapid tests that are treponemal tests, which detect antibodies to treponema pallidum proteins, the causative agent for syphilis, offer advantages for more remote settings with small numbers of pregnant women and no laboratory. Antibody tests that are non-treponemal tests, which detect antibodies to non-treponemal elements, such as rapid plasma reagin, or RPR, and venereal disease research laboratory tests, or VDRL, require basic laboratory equipment and skills. Both RPR and VDRL testing is inexpensive, but rapid testing may be a more expensive option in some settings. However, rapid testing is simple to perform, whereas both RPR and VDRL testing require training and equipment. This is why rapid tests are preferred in order to increase the number of pregnant women screened for syphilis and allow for same-day treatment. In settings with high syphilis rates, it will be important to test pregnant women who are positive with rapid tests using RPR VDRL in order to determine whether the infection is active syphilis. Qualitative titers of RPR will also be useful to monitor the response to treatment. All of these tests are suitable for screening pregnant women, but RPR VDRL can produce false positive results due to other health conditions or infections. Download the reading materials for more information. Gonorrhea and chlamydia infections can cause serious problems in pregnancy for both mothers and neonates. Several reliable diagnostic tests exist for gonorrhea, including culture, gram stain in men but not for women, and nucleic acid amplification test and other molecular assays. Unfortunately, reliable methods such as culture and NAAT for gonorrhea require laboratory capacity that is often not available or is expensive, while simpler, more affordable methods such as microscopy with gram stain frequently give false negative and false positive results. However, tests for chlamydia are either expensive or low sensitivity, often producing false negative results. WHO guidelines recommend co-treatment for gonorrhea and chlamydia when either infection is diagnosed. An important advantage of gonorrhea culture at sites with laboratory capacity is that it permits monitoring of antimicrobial resistance data. In some cases, other healthcare facilities can send samples for culture using transport medium. We will look at an example in case study 3. WHO is currently supporting development of an affordable and accurate point-of-care, or POC, test with at least 80% sensitivity and 90% specificity. If low-cost rapid test or molecular assay is not available, WHO suggests performing a speculum examination and treating for gonorrhea and trachomatis if there is evidence of cervicitis. If a rapid test is not available and a speculum examination is not feasible or acceptable, WHO suggests treating people for gonorrhea and trachomatis, all people at high risk of STIs, and all people who have vaginal discharge on genital examination. Countries are encouraged to ratchet up clinical and laboratory capacity to better support detection of gonorrhea and chlamydia. Where feasible, speculum examination should be done at first ANC clinic visit and anytime a woman complains of symptoms. Where laboratory capacity exists, speculum examination and test results should guide treatment. Antenatal services should also be able to detect and manage common STIs and RTIs that may cause considerable discomfort, as well as adverse pregnancy outcomes, such as preterm labor. Simple microscopy, if already available, permits identification of trichomoniasis, bacterial vaginosis, and candidiasis, as well as signs of cervical inflammation due to gonorrhea and chlamydia. Please note that setting up new microscopy facilities is labor-intensive, requires extensive lab quality assurance or QA, and may not be cost-effective. In addition to recommending methods for STI diagnosis, the SOC should clearly indicate first and second-line treatments for STIs and other RTIs. National treatment guidelines from the Ministry of Health are usually the reference for all healthcare facilities. Treatment guidelines should be optimized to provide high cure rates and prevent the development of antimicrobial resistance. It is especially important to base national treatment guidelines on the patterns of antimicrobial susceptibility to gonorrhea. WHO has developed and periodically updates global treatment guidelines for STIs. The Ministry of Health can refer to or adapt these tables in developing their national guidelines. Aware or access, watch, and reserve is another important tool for developing treatment guidelines. The aim of the AWARE classification of commonly used antibiotics is to reduce inappropriate use of watch and reserve groups by prioritizing the use of access antibiotics. These tools may be useful to ministries of health in developing national guidelines and to healthcare facilities, or HCFs, including private facilities, in adapting standards of care. When implementing standards of care, HCFs should ensure that recommended treatments are made known to clinicians and are available at their pharmacies. Treatment guidelines and standard of care should also address common prescribing errors that contribute to antimicrobial resistance. 9 common areas for improving antibiotic prescribing, which can be adapted to treatment of STIs, include 1. Overprescribing. 2. Overly broad spectrum. 3. Unnecessary combination therapy, including fixed-dose combinations. 4. Wrong antibiotic choice. 5. Wrong dose. 6. Wrong dose interval. 7. Wrong route. 8. Wrong duration. 9. Delayed administration. Up-to-date treatment guidelines help to ensure high cure rates and prevent development of antimicrobial resistance. Reaching these objectives also requires careful attention to both infection prevention and control, or IPC, and antimicrobial stewardship, or AMS, principles. Countries should consider conducting clinical audits periodically to improve rational and responsible antibiotic use. You have now completed Unit 2, Detecting and Managing STIs. We will now explore the topics we have covered in context using 3 case studies.